Dr. Ramesh KEKUNNAYA for speaking on what's new in myopia. Dr. Ramesh is one of the best in the field of pediatric ophthalmology, and on several occasions or most of the occasion in conferences I meet him while he present pediatric cataract on pediatric cataract, although he does all the best possible pediatric ophthalmology. Dr. Ramesh, please. And time allotted is about 9 minutes. So because we have to finish in time also. Thank you so much.
Thank you so much, Dr. Jagatram, for this introduction and having me here. Very good morning to all of you. We are going to talk about something very important to all of us, not only pediatric ophthalmologists, all the ophthalmologists. We deal with myopia day in and day out. So I'm going to talk about, there are some therapies which has come to prevent the progression of myopia. I'm going to highlight on some of them because you can talk about it for 45 minutes. Some of them are controversial. So if you look at the risk factors for myopia, it's multifactorial, be it genetics, near work, peripheral blur, peripheral refraction, light exposure, and also if you see the near work can have some unknown etiology in unilateral myopia, what happens once you patch, and also the severity and the screen size and the illumination. There are many factors. It's almost everything. It's like a COVID. We have something coming on a daily basis. Many people are just to understand that. And we know these factors like outdoors, light levels, whether it's UV light, vitamin D, all of them are contributing towards preventing myopia. If you look at the article, if you open the PubMed today, there are 3,000 plus articles are there. You know, if you have to be updated, these many articles you need to go through. So I'm going to show, because myopia, according to the prediction, this is one of the paper from our institute, we are at 2022 actually. If you look at 2050, close to 50%, that's a prediction of Indian scenario. It's ever rising in terms of the incidence. And once a myope, you are a lifetime myope. It's not that you're going to change. So the effect on the myopia, on glaucoma, cataract, retinal problems are going to continue over a period of time. COVID has given us some insight, home confinement with the screen time. There is a definite increase in the myopic shift. This is one of the things which is published in early 2021. And also, what kind of light? This is something new we wanted to study. We put the experiment on red light, blue light, green light, and the white light. What is the effect of this on myopia? Because we are even trying to see light therapy for myopia along with other pharmacological treatment. Towards that end, we started this project. You can see that effect of short wave, that is blue, and the middle one is green, and the red on axial elongation. That's the setup of our lab there with different light. And we have given a washout period of 10 minutes for each of these patients. And you can see the effect on the axial length, what you can see here. So if you see this is a very important chart. If you see the red and green can kind of increase the axial length, blue light is protective towards myopia. That's what we have found in this range of patients. So blue light seems to control eye elongation. We also had developed the in-house product called MyLight. It can even track the light exposure for a child, because they can keep it like that. You can see in their pocket, they can keep it. It's a very less expensive instrument, and blue light is shown to be effective in terms of controlling. This is one of the things apart from many things. The next one, what is being studied is the reading from smartphone is better or hard copy for the same. Here we had involved little bit older individual. You can see the age range from 18 to 30 years. 45 participants with an experimental study. You can see the effect. This is what we did, occlude one eye and then give them all three: book, video games, and the screen time. These are the three things we have given, and this is the experiment. You can see the lower lag with hard copy on accommodative lag is lower with hard copy, if you can see in this chart. Greater changes in axial length with hard copy. This is something surprising. Many patients and the parents ask, is the screen time better or reading from the book is better? So there is still some controversy. It's not the only factor which is, there could be a combination of, we also checked the, the changes in the vitreous chamber depth and also anterior segment length on these things. As you all know, myopia is caused by mechanical theory and also lag theory. That's why checking the axial length and the accommodative lag is very, very important in giving a customized treatment for the patients. So what's really wrong with single vision glasses? You can see if you don't correct both the central and the periphery becomes hyperopic defocus, as you can see. Single vision if you give, see what happens to the peripheral. That triggers the myopia component. And what is desired is central full correction with relatively, if you keep them peripheral myopia, this is good. That's why these three options have come: orthokeratology, peripheral defocus lens, low dose atropine that are close to 20 RCTs at this point of time. This is one of the study which is shown the efficacy of spectacle lenses with aspherical lenslets. This is what it prevents from peripheral hyperopic defocus. You need to create a peripheral myopic defocus, what you can see here. Highly aspherical lenses, this is one of the paper published in JAMA, is better than mildly aspherical lenslets. So this is what is the mechanism. You can see a multiple holes there with the spectacle, multiple lenses. And if you see the low dose atropine, these are the landmark studies: ATOM 1, ATOM 2, ATOM 3, LAMP, first phase, second phase, and the third phase. And absolutely, there is one study from us, our country as well, Indian ATOM study. So these are the landmark studies, what has happened. And if you see this chart, you must know that lower the dose is much more effective in the long term. Higher the dose, it is effective, but in the long term, they can have a greater rebound effect. So when we choose, the LAMP study says that 0.05% is good, but what the ATOM showed is 0.01%. So there is a slow drift. These are all I'm going to skip because I assume all of you know about ATOM 1. This is what is the change in the two groups, 0.92 and 0.40. And this is about ATOM 2. You can see the long-term effect of 0.1% and 0.5% over a period of time. Very minimal side effect. This gave a lot of confidence in using the lower dosage. And then LAMP study came. It's tilting more towards 0.05%, which is a balanced dose in terms of pharmacological treatment for the myopia. So this is what at this point of time, probably more studies are required in different populations. And they also, the latest is the phase 3 report of LAMP study. This study shows that during the third year, continued atropine treatment at any of the three concentrations confers better efficacy than stopping it. Over a 3-year period, 0.05% is more than double that of 0.01%, because this is something very, very important for all of us. And a greater rebound effect was associated with higher atropine in younger patients. So these two are the key words we must understand when we customize the patients with atropine studies. So this is Rohit is here. His group did this multicentric randomized control study. This is again saying that 0.01% about in 54% of the patients. So That's 5 years. And also there are studies to say over a period of time which is the best anti-myopia strategy. Anti-myopia 1, 2, 3, 4. What is the cost involved in each of this over a period of time? If you look at this busy graph, the atropine is the least expensive, but it may be balanced against other things. So I would like to end with one more final thing that there is a group of myopia. We do even eco myopia clinic because any one of you have cases to present. We have it on a monthly basis. And also there is a customized treatment in the myopia center. Whenever they come, identify the risk factors, then look at comprehensive examination including vision, refraction, anterior segment, posterior segment, including imaging and all the peripheral refraction and also the axial length. And photography also we do it, and then come to a conclusion, okay, this is the customized treatment for this particular patient. These are the things what is there at this point of time. You have bifocal lenses, you have natural therapy like time outdoors, probably will come with the light therapy also for myopia, various concentrations of atropine, orthokeratology, because I could not cover everything, where exactly it's useful, and even the central distance multifocal contact lens. All of them have a role, but one must customize this treatment for all of these patients. So in summary, myopia can be axial and non-axial. This is very important to establish, especially because I see these drops have been given to every patient. Sometimes the progression could be the lenticular as such. We need to understand that. And there are numerous anti-myopia strategies available. Treatment must be customized to every patient. And low dose atropine still continues to be one of the safest option in most of the cases, if not all. Thank you so much.
Thank you, Dr. Ramesh, for so much useful and new information in the field. Maybe one
there's a small change in the schedule. We would request Dr. Anand Venekar to come and present because he has...
Dr. Ramesh, please, I would like to kind of summarize and also have some clarification. So as of now, all the strategies that we have discussed in your paper, the most accepted is increasing the outdoor time and various doses of atropine, preferably 0.05%. And how do we identify a patient like that? You see a child with myopia, then do you observe a progression for say 6 months or 1 year before you begin the atropine, or you see a patient and you begin the atropine?
Yeah, there are 3 categories. One is pre-myopes, where we start the anti-myopia strategies in the form of natural treatment. Reduce the screen time, increase the outdoor activities. Even it applies to astigmatism and even hypermetropes. If they have myope, if there is a progression of 0.5 diopters in the last 6 months or 1 year, we start the therapy. What treatment to start? It depends upon number 1, the axial length. Number 2, whether the patient has accommodative lag. Number 3, whether the patient has peripheral defocus. We need to do an open autorefractometer. With that, we can start atropine, which is the most common. You can also give contact lenses. Second option, that's PAL lenses you can give. Third option is the peripheral defocus lenses, which are available. They are expensive. And the fourth one, it can be a combination of these 3 things.
So
Depends.
Actually, before we begin the treatment at all, we have to observe the child for at least 6 months.
Correct. If you have a documented, they have visited somebody else, you can already see the axial length is increasing. It's better to intervene.
Yes, that is right. So we should have a documented increase